Hello, this is Dr. Mark Dougherty. I'm here with my partner, Dr. Dan Rodrigue. We're giving another COVID update. I think this is our 8th one. We were giving them every couple of weeks at the beginning of the pandemic, and now it's been a few months, and we figured it was time to do another one. It's the anniversary, essentially, of the pandemic here in Kentucky. A year ago in January, we saw that a major crisis hit Wuhan, China. We were alarmed by that. Then disaster struck Italy in late February, and we were even more alarmed. If that could happen in northern Italy, we knew it could happen here. They ran out of hospital beds, they ran out of healthcare workers, they ran out of ventilators. No one over 65 was placed on a ventilator. If you were under 65 and had a comorbid condition, you didn't get a ventilator. And there was a very high mortality rate. We had a sense of impending doom. Well, what happened over the last year? In Kentucky, nearly 5,000 people are dead. In the US, 525,000 people are dead. Globally, we have 2.6 million dead, all of which are continuing to progress, although in Kentucky and the US, we're on a significant downward slope with significant improvement. With this sense of impending doom, we wondered, will we have enough hospital beds? Will we have enough healthcare workers? Will we have enough ventilators? Will we have enough personal protective equipment? Those were all, extremely anxiety provoking. We learned with the PPE and struggled at first, and we finally figured out a way to have extended use of the PPE in a safe fashion and gradually increased our supplies of PPE and overcame that struggle. We had incredible difficulty in the beginning with COVID testing. We didn't know who really had it and who didn't. Did they have some other respiratory illness? The PCR tests were taking about 10 days to come back. And that resulted also in us wasting a lot of PPE in patients who didn't have COVID. The other thing that was kind of striking at the beginning of the pandemic here was, we recognized that this was in China and Italy, this was a respiratory illness. People developed hypoxia, went on the ventilator. But what we didn't really appreciate until we got hit with it here is that it's a multi-system illness. Our first patient here had a major hemorrhagic stroke and then died. And that's COVID. We didn't realize that until right as he was dying and the test came back positive. Some of our other patients came in with DVT and bilateral pulmonary emboli. That's COVID. Other patients came in with myocardial infarction. That's a COVID presentation. So it was an illness that we didn't really fully appreciate the extent of and how it was a multi-system disease rather than just a respiratory illness. We struggled over interventions. At first, we were told that there were theoretical reasons that steroids shouldn't be given. It would increase viral load. It would probably prolong their illness, and they would potentially develop worsening respiratory failure. We subsequently learned a few months later through the recovery trial at the UK that steroids are a mainstay of treatment after patients have become more ill and developed pneumonitis with hypoxia. What about ventilators? At the beginning, we were told that in China and Italy, you look to put people on the ventilator if they went past 6 liters of oxygen. So that's what we were doing at first. But then we realized that no, patients in that situation can potentially have more complications, and instead we should try high flow oxygen, BiPAP, and other interventions before proceeding with the ventilator. Over the course of the pandemic, we've made progress in therapeutics with remdesivir, with preventative interventions, monoclonal antibodies, and now finally dramatic interventions with vaccines. Dr. Rodrigue will now talk about the epidemiology, therapeutics, and vaccines.
Thanks, Mark. Let's what we're trying to review is some epidemiology, some of the treatment background and prevention. Here's where we started. December 19th, there was a report of a series of pneumonia cases that were fairly severe in Wuhan, China, and it was sequenced as a novel virus. 1 year ago, this is a picture of a Kroger grocery store down the block where I went shopping, and clearly something was different from what we had before. There was a palpable sense of fear amongst in the community, in our healthcare setting. We were trying to figure out how we were going to combat this. Lots of meetings were had where we're getting together, trying to figure out our approaches. And this is the data that we were starting to look at. This was the initial outbreak study out of China showing that in December or so, you had this large increase in this respiratory illness that had significant outcomes in terms of people dying. Hospitals with pictures showing waiting rooms and no beds available, and it looked horrific. And then the first slides coming in, this is one of the first slides from a year ago from WHO, showing that while it started in China, if you look at the red dots, it was spreading across the world. And there was no published data at this point. There was a lot of phone calls, a lot of news media coverage, but clearly it was an ongoing situation where the healthcare systems were getting overwhelmed. We had descriptions of the outbreaks, it affecting primarily older people, but everybody was involved. Healthcare workers were involved. The initial reports from China were that maybe 3% of their healthcare workers were getting infected. It again contributed to the sense of something that was truly coming our way. A year later, clearly it was affecting the entire world. If you look at this WHO map, this is from the last 7 days, and this already is a dated slide. But if you look at this, at one point, anything that's on this map was dark. And meaning the darker the color, the higher the number of cases. And it was a worldwide phenomenon. If you look at Kentucky's map, this is from as of yesterday. This map, even as of, I'd say a month ago, was completely red. Every tile in this, every county was completely red. So within the past month, you've had dramatic changes. It's just been an amazing situation. Globally, we have 117 million to date cases, 2.6 million deaths involving the entire world. United States, 29 million, 525,000 deaths. We called, WHO called their first, it called it a pandemic almost to the year ago. 3/11/20 is when they announced it as a pandemic, and the United States called it a state of emergency on the 13th of March, again, about a year ago. In Kentucky, we have over 400,000 cases, almost 5,000 deaths. And at one point, again, within the last month, we had a positivity rate of our tests of in the double digits. And the state incidence rate being well over 100. Now it's 15 per 100,000. So things have changed quite a bit. The infection fatality risks, initially we were looking at very high case fatality rates out of China, over 3 point something percent. And now as time has gone on and we've had better diagnostic testing, the infection fatality rate has decreased. We knew that higher risk, that there were some instances where patients had higher risk, and that we started to, and you do this by describing the cases that you see initially in China, and then cases as you see it across the world, and looking at their individual risk factors, the comorbidities. So looking at that data, that's how you start to tease out patients with diabetes, patients with chronic illness, age, cardiac disease. 8 out of 10 deaths in the United States were over age 65. We got an idea of the incubation period. Most people developed the illness within the first week, but there was 2 to 10 days incubation period. Race and gender were mentioned, and they're still being looked at as risk factors for illness. Blood type O being looked at as a risk factor for more severe illness. And we saw that children really weren't that affected, although they did have some peculiar clinical signs. This isn't a surprise, but we have the initial case definition, and the case definition, remember, is based on trying to make sure everybody's talking about the same illness. That's how you start. You don't actually start. We didn't have PCR tests to begin with. We had a clinical syndrome, which you define as strictly as possible to capture the right illness. You don't want to say that anybody that has just a little fever has COVID, because you would probably overcount a lot of different people with a hangnail, or people. You really want to be more specific. So you start with a case definition. That's what was used initially as we're seeing patients come in. And that has its shortcomings. A case definition is used from an epidemiologic standpoint to really make sure everybody's talking about the same illness. But as a clinician, I have to take that, but also take the patient that comes in and try to taper that to use the right clinical definition. As time has gone on, we develop testing like PCR testing and antibody testing, and then we start to go backwards and look at, if you have an antibody test that's reliable, what is really going on in the country, what is really going on in different age group areas of the country in terms of who had evidence of having that disease. That's why we get to seroprevalence. We didn't have seroprevalence to start this outbreak a year ago. Now we're starting to see some of that seroprevalence data. So if you look at seroprevalence data, one of the things it teaches us, which again is not a surprise, is that we're probably even undercounting the number of COVID cases that we had. Oftentimes, especially with a new illness, what you tend to get reported is the most severe cases, the cases that end up in the hospital, the cases that end up going to a primary care physician's office. But in reality, that oftentimes represents only a proportion, a small percentage of the total number of cases. And then in this case, we're starting to get some of that information, and this data is coming out, I'm talking about within the last weeks, where we're starting to have sera surveys come back and tell us, wait a second, we may have more cases than we thought. So one study here that's printed is looking at all dialysis patients across the country and recognizing that if you look at a sample across the entire country, you can see quite a variation of differences in percentages of positive testing for COVID. If you look on the East Coast, you tended to have a higher proportion of cases, again, along that corridor that had the severe outbreaks, New York, Connecticut. Whereas on the West Coast, not as much, and in the Midwest, again, fairly low seroprevalence. Interestingly enough, of those people that had evidence of disease, only 10% of those were ever diagnosed as having COVID, which is a signal that, again, we're probably undercounting some of the COVID cases. If you look at globally, this is something that just came out yesterday. I think it came out just yesterday in the Lancet. And some of this is pretty small. Globally, the seroprevalence was about 8%. And this was a meta-analysis of something like represented 5 million patients across the globe, 5 million persons across the globe, a seroprevalence of 8%, but it ranged from 1% in the Western Pacific to 19% in Southeast Asia. And we got some signals about who was at risk. This is globally looking at who turned positive for testing for COVID. If you had close contacts, maybe up to 20%, high-risk healthcare workers versus low-risk healthcare workers. The difference between those two categories was the use of PPE. In some countries, for example, a report out of Vietnam, they had 40 to 50% of their healthcare workers getting infected, but they had no COVID wards, they had no PPE, and those patients got sick. The primary route of transmission still is respiratory, but as time has gone on, we've also appreciated, and this was talked about in the very beginning, that aerosol transmission is a possibility. We focused on aerosol generating procedures to talk about risk and when to use N95s. But conclusively at this point, there's still some confusion within the media and confusion within what people discuss. Primary transmission still is respiratory, face-to-face contact for explaining the majority of what's going on in our communities. But we know that you can have aerosol and it becomes an important situation, for example, within areas that are poorly ventilated, because we can generate some aerosols with even a normal conversation. But the majority of transmission still, even when I'm having a normal conversation, is my respiratory droplets that I might generate, not so much the aerosol. And looking at the outbreak situations and the different individual studies, whether they're household transmission, restaurant transmissions, et cetera, the majority fit more of a respiratory droplet being the primary source. When we started this a year ago, within the first couple of months, people were doing laboratory studies. And clearly we could identify that surfaces were getting infected, at least identifying PCR droplets, PCR positive samples from different surfaces. And there was a big to-do about whether it was a cardboard box, whether it was a plastic thing. But a year later, fomites really are not panning out as a major focus. Can they be part of transmission? The answer is yes, but are they a major focus? The answer is no. Does it mean we eliminate hygiene? The answer is no. I mean, certainly high touch areas in your house or in your hospital, door handles, et cetera, we really want to maintain hygiene. But in terms of it leaping off a door handle and going into your lungs, that really hasn't panned out. So fomites are a potential route. You can find PCR evidence of a virus there, but in terms of a major focus of infection, the answer is probably no. The other big story that changed over the year was, remember when we started, we had examples of coronavirus in SARS-CoV-1, that's the original SARS, and MERS, another coronavirus that was involved in outbreaks. And looking at that data, most transmission occurred when a person was symptomatic. But in this outbreak, it was different, and we had to take time. This is within a year. It took time. It took some months to find out that actually before you're symptomatic, you still have a very high viral load, and you do participate in transmission. So pre-symptomatic transmission changed the ball game in terms of what we were using for prevention measures. To begin with, we really didn't think about using masks on a community-wide basis, but then the recognition that asymptomatic patients had high viral loads and were probably involved in 40 to 50% of transmission led to a change in recommendations around April in the country and by CDC, by different healthcare experts. Now, what did that cause? That caused some confusion, and it also caused people to start to distrust that this is a conspiracy. Maybe why did they say one thing and then they said another? And there's something to be said about trying to have clear communication and explain the science behind what goes on, and try to sift through what goes on in terms of what media says and and understanding that the science changes over time. This has only been a year, and within a year, we've had more and more clarity. This is still a disease that is transmitted more like respiratory, and that's in the middle, SARS-CoV-2. 2 to 3 people get infected. That's a measure of the communicability. Measles is the classic airborne transmission virus. If you look at measles outbreaks within a household setting, 90 some odd percent get infected if you're susceptible. That really didn't fit the SARS model. So again, additional evidence showing that SARS acted more like a respiratory droplet illness. It was more contagious than typical flu or Ebola, but it was in that middle and not as contagious as measles. Here's some recent data on age. From the beginning, we had signals that age made a difference, and we're still trying to tease through. If we have time, we can talk about some of the reasoning why age might make such a difference, but it has a lot to do with your immune system, and that's something that we're learning to date. But look at the difference between being young and being over 85. The infection fatality risk is almost 30% if you're over 85 versus almost nothing if you're 0 to 34 years of age. It's been mentioned that why make such a big deal? Because this is actually mentioned in somebody's article about a day or two ago in the media. They're saying that we're making such a big deal, nobody dies. It's, they have more of a chance to die of an automobile accident. Well, actually not quite true. If you look at what your chances are of dying from an automobile accident, even if you're not getting sick or dying at this young age, it's still higher than automobile fatalities or other fatality risks. Oh, one other thing I wanted to mention. This is a quick thing. Look at the bottom of the slide. I just put that in there because there are some unique aspects to try to figure out disease on a global basis in terms of outcomes. If you look at some of the African data, their fatality risk seems to be lower. And so we're always trying to figure out what are the risk factors? Why are people not dying as high in Africa as they would die, say, in Italy? And this has been mentioned, and they're trying to look at some of the reasoning. I know some of the typical things people are going to say, well, it's data collection, it's whatever. They're not capturing all the cases. And I think there may be some truth to that because systems are not always as in place in developing countries to look at some of that data, but still it's pretty striking. But looking at just age-related stuff, this is something that you might not be aware of. In Kenya, for example, only 3-point-something% of the population is older than 65 years of age. That's a lot different. From Italy, over 23%. So Italy's population, where they had significant outcomes, is so much older. You wouldn't think about that kind of stuff. In the United States, about 16% or so of our population is over 65. So there are some differences. You can't always compare apples and oranges. And when you have that public discussion, if you look on the internet, which again, this is the source of all information, some people will say, well, it's clear that it was the ivermectin use in Africa because they use a lot of ivermectin. That must have been the absolute reason. Well, it doesn't really account for some of these other differences. You already have a fairly low risk population in terms of age and also in terms of social structures. There are not a lot of people over 65 in Kenya that are in nursing homes. There are not a lot of people that are as overweight. It's just a different structure. So it's not, you can't infer that ivermectin use was the reason. Now, it doesn't mean that you can't study ivermectin. I think it needs to be studied, but you can't use that as a general lever without looking at all this other information. So our COVID hospitalizations are definitely going down. You can see that here at the end of February, regardless of what your age is. What a plummet in terms of what's happening. This slide probably should have been bumped up before this last slide, but your weight is a major issue. So we talked about comorbidities. Age is a major issue. Weight is a major issue. Looking at this graph, the higher your BMI, which is on the bottom rung, regardless of your age, because there's different, this is broken down by age, your risk for hospitalization, for being in the ICU, for mortality, for being on a ventilator goes up as your weight goes up. Hospital outcomes. This is the first 6 months. We don't have data published on the last, but mortality rate was still close to 14%. Your mortality improved as the time went on in the outbreak. To start with, the mortality rate of in-hospital admission by month in March, that's a year ago, mortality was 22%. By August, where we had more treatments available, understood the disease a little better, the mortality rate dropped to 6%, 6.5%. Your mortality also varied by age, which we've all talked about. The median cost of stay was about $40,000 if you're in the ICU. Healthcare workers were always a part of this to begin with, because they're on the front lines taking care of the patients. And out of China, they reported that healthcare workers were getting sick. That's the same. That's similar to what happened in other SARS and MERS outbreaks. Healthcare workers did get sick, and they're part of this. It depends on, if you're looking at the seroprevalence in healthcare workers, it really depends on where you do the study, when you did the study. If you did the study when there wasn't a lot of disease in the community, there wasn't a lot of disease in healthcare workers. If you did this study when there was a big flare and a out of control outbreak in your survey, healthcare workers more likely to get infected. So it depends on when and where those surveys were done. First responders were also involved, public safety workers, looking at different groups. If you look at the Baptist system, just the Baptist system in the last year, this is from Baptist data, almost 4,000 people were positive. Now this includes everybody in terms of Lexington Baptist Health, Lexington's employees, about 480 people were infected at the time. Every person that became infected within the system, we always tried to look at risk factors. About half the time it was potentially exposure to in the hospital setting. Half the time it was exposure really to outside communities. And if you look at the general information around healthcare workers, the majority of the time that a healthcare worker got infected, it was usually from community exposure or family exposure, or lack of PPE or lack of use of PPE, which is not a complete surprise. When you look at COVID and the healthcare worker, stress and burnout were common. This was stressful. I mean, there's no doubt about it. For a year to be involved, not knowing if you were going to get sick, if your family's going to get sick, if you're going to get your family sick, your spouse sick, your spouse is going to get used, so many combinations. The issue of masking and isolating, it was a very isolating experience and difficult to deal with. And the death that we saw, we don't see that much death from infectious diseases for the most part. That was stressful for us to deal with. So that was mentioned in numerous articles over the past year. Pregnancy gets a slide here because we have some data published recently on numbers of cases. So within the past year, 12,000 pregnant women were hospitalized. The majority of those people did well, the majority, but still a percentage of them had ICU admission or required ventilation. If you compare, this is on the right-hand slide, you have the age group. They tended to be a younger age group. So overall, the risk factors for having a bad outcome were low. If you compare them to the same age cohort, pregnancy did have an increased risk for an adverse outcome. So amongst young people, because most pregnant people tend to be younger, they're not going to generally do as poorly, but those people had a slightly increased risk. That has led to some of the issues addressing vaccination versus no vaccination. In terms of outcome of pregnancy, you tended to have people that had, earlier deliveries and not a lot of vertical transmission, if at all. But some articles hinted that there might have been some vertical transmission, but for the vast majority, no. Remember when we started to compare this to other outbreaks in the beginning? The very first time I saw my first case was in March. That was the person that presented with the stroke and died. It was not a classic COVID presentation. The time I saw that patient, we had 10 patients in Kentucky and 2,000 patients in the country. And so we were asked to start to talk about how does this compare to other outbreaks? And most of the time, the general consensus in the media was don't scare anybody. Don't ever compare this to the Spanish flu. There's just too much havoc. This is just still new. Let's not get there. Well, we're there. This is still probably the biggest pandemic we've had since 100 years ago. When you talk about the Spanish flu, our cases in the U.S. from the Spanish flu, we had 675,000 deaths. We're going to top that likely in the U.S. And that outbreak lasted 2 years. This outbreak has only been 1 year. So it is significant. It did lead to some of the similar measures that we had to use back in the Spanish flu in terms of closing down business, closing down activities to try to deal with it. So it does have a lot of similarities. This intersected with chronic disease. We already know that chronic disease in the US in terms of obesity, hypertension, cardiac disease was out there. And when this illness hit, those were risk factors for having a bad outcome. So it definitely impacted our difficulties with controlling some of those chronic illnesses in the US. We probably have had 3 waves to date, which is similar to looking at, for example, the Spanish flu. You didn't have, that came in waves, a lot of times correlating with seasons. So our first wave was introduction into a naive community. That was back in early January, when we're talking about Washington, or potentially in December when they went back and looked at some autopsy cases in California. Letting it circulate in the community, getting it magnified. That was our first signal that congregating the elderly in nursing homes was going to be a problem. You started with a few nursing homes and then you spread like wildfire across the country with nursing homes. The second wave marched to the summer of 2020, had sustained community transmission. It started to increase. It started to intersect with the chronic illnesses. All the states were involved by the middle of March. Then we have areas, I mean, it goes into areas that had the setup for disseminating. So how we deliver our food. See, people don't know how we even organize our society right now. They have no idea. I go to Kroger and I pick up a steak or a piece of chicken and then I grill it or something. I have no idea how things are organized. They're organized in concentrated areas. How we deliver our food, how we deliver, it's all a factory process to spread that out to the whole country. Well, if you're working in those big factories, you had a great opportunity to spread the illness, a respiratory illness. So that's what we started to see. Food factories, anywhere we congregated. So we started with the nursing home signal. Then we looked at prisons, food delivery. It really showed us a snapshot of something that I think most of us don't think about, and that's how our society is structured. And then we started to understand that, so we implemented controls, which did work in a lot of these settings. And then we had a third wave where it was difficult to maintain some of those controls as we congregated for holidays, and then again spread it out into the community. And then now we're finally decreasing it as we implement additional control measures, including vaccinations. Variants are important. Variants started from the very beginning. We didn't really, people were looking at variants. They were looking at sequencing the virus. You know, when you look at this, remember it's an RNA virus. It has different parts that make up the structure of the virus, the spike protein, the nucleocapsid, the membrane, all the different parts that make the whole of the virus. You can go back and look at the genes that code for that. We were looking at that at the beginning, but we were not really ramped up in terms of looking at what the importance was. So as time has gone on, and this is again, information that has been coming out in the last couple of months, we start to identify variants, changes in these viruses that seem to have more importance than others. there are thousands, and this happens to a lot of viruses, where you have thousands of changes. Not every change made in a virus will necessarily create a supervirus or something that gives it an improved advantage in terms of circulation or trying to hurt the host. But we have come down and found some interesting features. When you do sequencing, it's like fingerprinting that virus. You could demonstrate that within certain communities, such as the UK, you started to have the sweep of a specific strain, that B117 strain, and they could pinpoint the types of the changes and what did that mean. And they start to have to go back and look, doing it at a different level, using the fingerprinting. Is that a more virulent virus? Is that a more transmissible virus? And the answer is, it is more transmissible. Is it more virulent? That's something that they're still describing. And they could narrow it down to what are the actual genetic changes in that virus. It turns out it's a change in that spike protein, which is not uncommon. The spike protein is where we generate a lot of our immunity, antibodies against that spike protein, which has to be used to bind to your ACE receptor and then cause disease. So they started to focus on these things and found different variants. South Africa developed had a evolution of their own particular strain. Brazil had their own particular strains. Within the US, we're following different variants. That issue is an ongoing issue that still remains important, that will still be monitored, and has taken some time to ramp up, because the technology used is not something that a Walgreens can do. It really has to be a public-private partnership, which is going on between CDC, between state health departments, between university labs and consortiums trying to increase that kind of surveillance. That is ongoing. Could it have been done sooner? I don't know. I mean, where everybody's doing things simultaneously, and the amount of money and effort and infrastructure involved really took time to kind of ramp up. But here's part of the reason why people are concerned. If you look at this graph published at the end of January, Brazil, which didn't have a rollout of the vaccine at this time, just had a natural immunity. So it said by October 2020, where that little red arrow is, it was estimated that almost 80% of the population had been infected by serosurveys with a previous strain of coronavirus. But all of a sudden in January, you started to have a marked increase in hospitalizations and adverse outcomes, and a second lockdown had to be instituted, because a new variant called this P1 variant with significant changes showed that even previous immunity didn't seem to protect you from this new variant. So more to learn about this, and it did have outcomes. I mean, this is a real-time photograph of them digging new graves in Manaus, Brazil. So it has a consequence. Interestingly, I would say that this doesn't address the issue of vaccination. These people were not vaccinated. And so what it might tell you is that we know vaccination actually gives you higher titers than routine infection, especially if you're mildly infected. So there's more to be learned from this. Here's another outcome of simultaneous what is going on with the flu. So while we had a major outbreak of COVID, the flu is not here right now. In the red, this is a comparison of different flu seasons. The 2020-2021 flu season is the little red triangles there at the bottom. There isn't much flu. This is the lowest flu season we've had in decades. And it's probably a function of us doing the same measures to prevent COVID has actually had a marked benefit in terms of preventing influenza. Clinically, let's move on. Symptoms weren't easy to diagnose. I mean, acts like a viral illness when you start off, but certainly there was some signals that something unusual was going on. Taste and smell loss were presenting signs. First week viral load was high, you developed antibodies, and then the second week you had a inflammatory syndrome, which led to a lot of the illnesses. And clinically, it could affect the whole body. And as was mentioned before, oftentimes you had unusual presentations. So my first case was not coming in here saying, I have a cough, I can't breathe, blah, blah, blah. It was, this person had a stroke, and the recognition of increased coagulability, increased inflammation has been a feature that gives you some of the uncommon presentations. People presenting with stroke, MIs, rashes, Guillain-Barré. A patient I had yesterday presented with Bell's palsy and not presented with typical COVID. And then pre-op testing. Remember, we initiated pre-op testing because we wanted to make the place safer. And lo and behold, pre-op testing, initially people were saying, well, why are we doing that? They're not symptomatic. Well, it turns out that we were, especially as the virus increased in the community, a substantial number of the pre-op patients were positive for COVID. Here's our classic findings, and we know that the main issue with COVID, while it affects multi-system disease, still is focusing on a lot of the lung in terms of the injury and how patients do poorly. And diagnosing it, here's where we started. This is the person of interest form that CDC was circulating, and I'm sure the print is too small, but if you look at it, initially, to get a test, you had to have some kind of exposure to Wuhan, China. And that was a strict criteria, because if you didn't come from Wuhan, China, you really didn't fit the case definition, and you weren't getting diagnosed. And clearly, a year later, this form is really not as important in terms of making that diagnosis. To begin with, we had lots of issues trying to get testing back. We had to use clinical criteria, CT scans. There was all kinds of arguments about who should get a CT scan, what criteria we're going to use. It was difficult. Now we have lots of different platforms. There is still a discussion about the best way to use some of the testing. For example, potentially, especially for outpatient setting, using some of the antigen tests for looking at the contagious aspect might be an important issue. Home testing is becoming more important. Cheaper testing, faster testing, that's all part of what's going on in the future. But in the hospital setting, our biggest issues are more severe disease and death. The most majority of patients that die usually die of a pulmonary illness. And the pulmonary illness is multifactorial. It's related, if you look at autopsy studies, they have lots of microthrombi, they have ARDS, they have multi-organ failure. And even, and these are studies that are published in the last month saying the same things. Interestingly, you could find the virus in a lot of tissues, but still the majority of the inflammation is in the lungs. It's not as much in the other organs. And when you look at those autopsy studies, you still get surprised by the percentage of patients that had clots that weren't suspected before. So how do we go about treating? So in general, same thing. Supportive care, oxygen required. We knew that that was going to be important. The majority of the patients coming into the hospital end up needing oxygen. And in fact, it's led to a global oxygen shortage. And in some cases, even within our own communities, we have been close to running out of high flow nasal cannulas because oxygen is a big deal. So when we have the large waves, and remember what we were talking about in the very beginning, to try to flatten the curve, to have everything catch up, supply chain, supplies, regardless of what it is. Well, in some areas, when you can't do that and you get overwhelmed, you run out of oxygen, you run out of beds, you run out of ventilators, and it's a mess. We learned about the differences about intubating versus not intubating. We're not intubating, trying to not intubate as much as possible because of the difficulties with the damage that intubation, well, the damage that ventilation can do to the lungs, contributing to the inflammatory damage that occurs in the lungs. But some of those patients still need to get intubated. And our ICU data has shown us that proning is an important feature to try to help patients get better. And we have had to trach some of these patients and done it successfully. Fortunately, in Kentucky, we never really got to the point of running out of beds, running out of ventilators. We had to have those discussions. about prioritizing. We had those discussions in different university centers. They had to discuss how to triage based on whatever the factors may be. It was really a all hands on deck, try to figure out how to do this situation. Antibiotics are still commonly used, but as we've gone on, the majority of people coming in don't have infections, probably less than 10%, less than 5%. However, depends on when you're seeing that patient. So oftentimes later on, 3 weeks after their diagnosis, we do see some secondary infections and pneumonias coming in. Anticoagulation treatment has been an important feature. It is still an ongoing topic for conversation, but at least prophylactic anticoagulation is important. And in some trials, this is a trial that was just released at the end of January, looking at 3 collaborative trials that are ongoing, involving thousands of patients. The signal is going to be that we may need to consider, even for somebody getting admitted with moderate disease, full anticoagulation. That's something to be further determined coming up within the next year. We used convalescent plasma based on previous outbreak information. Its use dates back even to the Spanish flu and SARS and Ebola. And there's been other diseases where convalescent plasmas work. And at the very beginning, we didn't know what to do because we didn't have any other medications. So we did use convalescent plasma. And as time has gone on, I think we've sharpened our focus on which patients will benefit more from convalescent plasma as we understand the disease better, understanding that it's a 2-pronged disease, initially a viral disease, later an inflammatory disease. Probably don't need antibody treatments as you get to the inflammatory phase, which is after a week. So the earlier, and this was mentioned previously in the previous outbreaks of flu, et cetera, the earlier you use this medication in terms of convalescent plasma, the better the effect. So as time has gone on, some studies have clarified that, recently published within the last month, that probably that window initially of 72 hours is going to be important, where you still haven't developed a significant antibody response, but using high titer convalescent plasma does help. There's probably a benefit in terms of risk to progression to severe disease, and even a mortality benefit in some studies. But if you use it when your patient's already sick in the ICU on a ventilator, probably doesn't have a benefit. Monoclonal antibodies have a same situation where we have developed these products, bamlanivimab, Regeneron products, combination monoclonal antibodies. Same issue is going to be there. That is, earlier use, the better. Probably within 72 hours, the better. But as you get past and into hospitalized patients, if they're hospitalized for COVID, probably not as much of a benefit. Again, because that patient's probably already developed an antibody response. So giving him a monoclonal is not going to have as much of an effect. Remdesivir is the only antiviral that has been approved now for the use in treatment of patients. And the data wasn't great. The data was okay. Although when you looked at the press release, and it really lifted people's spirits. It was good. We had at least something developed. This drug had been previously developed looking at Ebola and other viruses and had an effect. And so remember, that was part of the whole wave in the beginning. We took data about what we had in the laboratory, what had previously been looked at, looking at in vitro studies to see what would potentially, and that's how we got the net was cast wide. Hydroxychloroquine, azithromycin, et cetera. All that stuff was cast wide. Remdesivir eventually made it through trials showing some benefit. But is it a complete game changer? It might not so much. And it may also be how we're using it. Again, it's an antiviral. So if I'm using it as in a treatment of somebody who's already super sick on the ventilator and in the inflammatory stage, probably not as much of an effect than if I'm using it earlier on. So the data are still, they support its use. It's become part of standard of care, but it wasn't a major game changer to date. But steroids were a major, this is from the recovery trial data. And it's amazing. If you were on a ventilator and you got steroids, your mortality at 28 days was reduced by 30%. That's a major impact. Now, if you weren't on any oxygen, and you can see that if you have readers, you can look at the down below, no oxygen needed on the left-hand side thing. It's no oxygen needed. It actually didn't. It might even be, usual care was actually looked a little better. So if you didn't have any oxygen use, steroids didn't help. But if you needed oxygen, there was a signal to say this benefited. And this started to, again, clarify that the disease was not all about the virus. It was a virus plus an inflammatory side effect of that virus. Tocilizumab was another anti-inflammatory agent that has come through, but it had to go through different trials to show some benefit. And again, very difficult when you're looking at treatment trials. Really depends on when you use the drug to show a benefit. It's kind of hard to think about, but for example, if I chose to use a drug and I'm saying, I want to use this drug at the very end, right before I'm going to choose patients that have 1 day before they die, and I'm going to try to use this drug and see if it has an effect. What do you think is going to happen? Probably not going to have much of an effect because those patients are already too far gone, very sick. So it really depends on where you put your drug use. Tocilizumab, if I'm using it at the very end where the patient's basically going to die and they're 100% FiO2, they've been there for weeks on end, probably not as much of a benefit. So it's difficult when you design trials to figure out the sweet spot where you think the benefit of the drug is going to be. A lot of that depends on your understanding of the illness, your understanding of the parameters that you're trying to affect, and especially in the context of seeing a new illness where you don't have all this information, you have to make educated guesses, and sometimes you don't guess right. So you look at convalescent plasma, for example, a lot of those trials were done on everybody, including patients that were already intubated at the end of their illness, didn't have much of an effect. So some of the studies reported convalescent plasma has no effect. If you don't understand the context of how things are done, you can't just generalize, which is what we hear when we hear the reports, especially on the media. Say convalescent plasma doesn't work. This doesn't work. You have to understand some of the particulars sometimes to get at that. And that requires a lot more education and dissection of the articles, which a lot of us don't have a lot of time to do sometimes. And even the researchers that present it don't present it clearly. So in the beginning, we had some of these trials that didn't show much of an effect, but the larger trials have shown an effect with tocilizumab. And it is trying to also choose the right time. So most of the trials are pointing to a signal when the patient is clinically deteriorating, showing need for higher oxygen, and then entering that ICU phase to try to pinpoint the use of this powerful medicine. And it does have an effect, but it's not always that clear. So I can present a number of trials that didn't show as much an effect and some trials that do, but on the whole, the weight of the evidence is supporting using this as an anti-inflammatory treatment that has some benefit. You look at the Baptist data, because one of the things that we did, and thankfully to the pharmacists and the people in the system, another good use of our trying to figure out if we're hurting or helping our patients. We're at least trying to get signals when we use some of these cases, because remember, we're struck with there isn't no standard of care. The standard of care evolves, but we also don't want to hurt our patients. The first rule of medicine is do no harm. Well, we're still faced with how to treat our patients and trying to take the science and trying to take the committees or general bodies like the NIH or the Infectious Disease Society of America and trying to take their recommendations, which sometimes lag behind what we have to do at the bedside. We don't want to get cavalier. So we started to look at our own information. Are we hurting our patients? If we, for example, treated every one of these patients and they all died and they died horrible deaths with bad infections, and we'd probably signal, whoa, we're not going to do it. So we did start to look at some of our own information. And looking at that, we had 26 patients we treated just at our local hospital, where we had a median age. They were obese, usually 7 days from testing to admission to administration, which fits with the inflammatory timing of the virus. Initially, you have a viral phase, and as you get into the second week, you have the inflammatory phase. Most of these people in the ICU, 40% or so required intubation. 2 out of 26 died. So interesting. It's not, the majority did not die. And these were the sicker patients. So that's a pretty good signal. Remember that the mortality rate when you're older and sicker was quite high. But the less patients seem to die. But this is not a randomized study. This is unpublished. This is really raw, but it still gives you a signal. And I would encourage every system at every hospital to do something like this, to at least give themselves signals. We have to harness the benefit of being in a system and using our information systems and our data, because it helps to inform us as clinicians. Did the same thing for baricitinib, another anti-inflammatory treatment, approved in November. This is 21, based on and actually approved in November of 20. It's my typo. Based on a multinational trial, showed a benefit in those patients that were sick, requiring oxygen, high amounts of oxygen. And we used it. So if we looked at, we used it in 35 patients. We didn't have a lot of other treatments. In fact, there was a time when we were using baricitinib more than we were using tocilizumab, because we had an FDA, emergency use authorization, and we didn't have much to do and much else to give other than steroids and remdesivir. And in our patients, we looked at it again, similar age range of patients, older, higher BMIs, length of stay fairly decent. The majority of those patients going into the ICU, median days of treatment were 8, and again, about a week after, which fit where our inflammatory disease markers are. And we had 6 patients. We had 6 patients die out of the 35, but we didn't have 34 out of 35 die. So maybe there was a benefit. These are high-risk patients, and it seemed to have at least no signals that all of them were getting septic and having horrible complications. Again, good information. Now, lots of other treatments you can bring up. I don't have all the information on all these. There's a million treatments. Like the last time I gave a talk, somebody said, what about vasoactive intestinal peptide? And I don't know. I mean, there's a million things. Remember, at this time, there's probably 60,000 articles, and buried in there might be the panacea. I don't know some of this stuff. I'm trying to give you, based on going through all the major publications and our major organizations, to figure out where the standard lies. But other treatments not supported at this time include hydroxychloroquine, azithro, and they're still discussing ivermectin, although there's a recent article in JAMA this last week that said there's no change in symptoms. And then vitamin C, zinc, vitamin D. There are articles that kind of go through that within the last couple of months, looking at trials that didn't show much of a benefit. There is still information to look at budesonide in terms of an inhaled steroid. And this new one that got, oh, by the way, I was told that 60 Minutes came out with this thing yesterday, fluvoxetine, that's an SSRI. There was a trial published in November, a randomized trial, but small, 150 patients, that seemed to show some benefit in terms of progression to a more serious illness. 0 patients treated with fluvoxetine versus 6 patients in the placebo progressed to severe illness. It's still a small trial, but they're going to look at that, and there actually are ongoing still large NIH trials looking at treatments. So outpatient treatments under investigation still include inhaled steroids. This is a new agent that's in the last couple of weeks has popped up. It's an antiviral, an oral antiviral, molnupiravir. It's a lot of words to say. Until I say it like 50 times, I won't be able to say it smoothly. It's an oral antiviral agent. Great. Maybe it's going to work like oseltamivir or Tamiflu in terms of an antiviral. Again, probably going to be focused on the outpatient treatment early. It's a 5-day treatment. Did show antiviral effect. It would be great. There's going to be new agents that come along down the line. So how do we summarize some of the treatment? At this point, steroids are anybody that's hospitalized requiring oxygen, is going to get steroids. They're going to get remdesivir, tocilizumab if they progress, or baricitinib, but probably more tocilizumab. And outpatient therapy-wise, we're thinking about still monoclonal antibodies for high-risk patients, and there's a whole section on what what's considered high risk, especially the earlier the better. And to give you the picture of it, here we have the illness again in the viral phase in the very beginning, and then the immune phase toward the end. We've kind of moved things around as time has gone on with this graph, but it has actually held up pretty true. Monoclonals and convalescent plasma early on as a treatment probably has some benefit, especially if you have high titer convalescent plasma, which in Lexington, we still had issues about getting titers. I don't think we have them yet. Decadron, remdesivir in the very beginning of your illness, if you are meeting criteria in terms of needing oxygen. And then more immune therapies as you go into that accelerated phase where you have a cytokine system that's out of control. That's where we are using the tocilizumab and baricitinib. And we are using it, and I think it's having a benefit. Then later on, considering bacterial secondary infections, we do have some patients getting readmitted with secondary bacterial infections, secondary bacterial pneumonias. If you look at the data on readmission, there are some articles published on readmission. Patients that are older, over 65, with comorbidities, not a complete surprise, but anybody with comorbidities and older tend to be at risk for readmissions. The long COVID is still something that's being discussed. It is a high number of patients that have something going on that's not well characterized. The most common symptom being fatigue and aches. If you're sicker, you will have some injury to your lungs, potentially your heart, and those patients need to be followed long-term. There are no standards in terms of exactly what we do with those patients. Sometimes those patients get repeat CAT scans, cardiac workups, but understanding that some of these patients may also end up in the chronic fatigue category for a while for unclear reasons. We don't understand chronic fatigue, but it's not an uncommon consequence of other illnesses that seem to have an ongoing immunologic issue that makes patients not feel well. And now we get to this. So community prevention. So masking and was recommended generally in the US. That major change occurred in April, almost a year ago, is when masking started to come on. And on the right-hand side is showing you general mask usage. And then the lower part of that is showing you the masking at a Georgia Tech football game in 1918. So it's an old technology, low tech. Low tech really had an impact on our illness. It helped us flatten the curve, catch up in terms of PPE, all those different things. That's still going to be part of community prevention, hand hygiene, and then the vaccination story. Masks have had lots of ups and downs and lots of studies. Even if you look at today's Annals of Internal Medicine, where they tend to give you updates. Their update on mask usage and healthcare workers and masks. The studies are very difficult to tease out because it's difficult to control for the percentage of people that actually use the mask correctly, what the setting is, what's going on in the community. On the whole, there are information like this. This is from an outbreak, remember, where if you go to CDC's website, you can see some of the buildup of the science behind why masks might be useful. This was that salon where persons came in there and got their haircut by two people that were infected with COVID. The people that were infected were using a mask the entire time, and everybody else did not get infected. None of those patients got infected. It showed some real life benefit. If there's plenty of studies out there looking at differences, and this, by the way, you can trace this stuff back also into previous outbreaks. What happened in the Spanish flu? If you looked at nationwide, one city would have a more strict mask mandate, one city not, and the differences in what happened with transmission. In this, there's articles like that in this outbreak over the past year. communities that had stricter mandates or better mask use, better social distancing use, and their impact. We could see the differences between the increases in the number of COVID cases. Now, during this last year, everything got looked at through the lens of politics. So it got to be I couldn't figure out who's a Democrat and who's a Republican or an independent, and how that affected mask use and all this kind of things. And, a lot of stuff got blown out of, but there was some science where they're trying to look at it. And on the whole, it had some benefit. Now, there are always going to be a focus depending upon, I'm trying to get you to watch my TV show. So I'm going to show you the most controversial thing and then get two people to contradict each other. And then I've done my job because you'll buy, Coca-Cola or something. But it's difficult to get some of the, tease out some of the differences, just like the therapeutics, where the truth lies. But in general, masking and social distancing, that really did have an effect. In our hospitals, it had an effect. In our communities, it had an effect. We do have studies that show there are probably better ways to use masks. So this just came out 2 weeks ago when they did a mannequin study and they looked at different ways to use masks. Now, unfortunately, it got confused. This was the double masking study where they used mannequins. And I tell people that my face is not like the mannequin face. So I tried doing these different things and it doesn't work that well on my face. But it showed that if you tighten this up, you're trying to decrease the gaps that we have in our masking, you actually improve the filtering capacity of masking. But remember that the data that we're using in terms of masking was to prevent, if everybody masks, source control was the important thing, not as much filtering. Although I will say that there's some interesting things also to think about. Masking, although it's not 100% in terms of filtering, it does do some filtering. And in fact, there are some data out there that show that it probably decreases your inoculum. So inoculum may have an effect in terms of how severely ill you get. So the smaller the inoculum, maybe the less ill you become, your body is able to handle the illness, which is not an uncommon concept in infectious disease. So there are benefits to masking that go beyond just source control. There's probably benefits to the wearer in terms of filtering some of that, but it's not perfect. So if I want to emphasize the controversy, I'll confuse you and present that. But where are we at in terms of controlling? This is a major thing, vaccinations. And we had the beginning of the talk about Operation Warp Speed. Now, unfortunately, a lot of this stuff, again, was politicized. We're going to get 300 million doses by January. But still, remember that normal life cycle of a vaccine to develop it is about 10 years. But within the year, we now have 3 vaccines. And we have new technologies that really, for the first time, seem to be effective. Unbelievable. It's awesome. And how are we using, we're using the genetic code to create the spike protein. And that's what the slide is showing. We trigger immunity, use a genetic code, putting that in there, making the spike protein, and your body recognizes the spike protein, thinks it's an infection, and starts the immune cascade, activating all these cells to protect you going forward. So our first approval for vaccine was with Pfizer, and it got its, its improved its approval in December. It's again using part of the genetic code, the mRNA, encapsulating it. That was required, developing that technology of encapsulating it, doing a large trial at 43,000 patients. Look at the dates. The trial was done between July and November because the dates of these trials are different. And it was required 2 doses of vaccine. It got a lot of publicity also because of the difficulty of storage, which is now changing some. But it was really, it had some efficacy. And then the Moderna vaccine came along and it got its approval after a trial. They finished their trial in October and they looked at 30,000 patients, also slight differences in terms of between first dose and second dose vaccines. And then lastly, the Johnson & Johnson vaccine, of which Baptist was one of the sites for that trial, using a adenovirus, which has been used in other vaccines. People were saying, well, this is a, using a virus vector and it's a live virus, but actually it's a virus that is very common. It doesn't really cause side effects. It's used in other viral vaccines, such as Ebola. Within the last year or so, it's been used to try to combat Ebola in the Democratic Republic of Congo, where they gave over 300,000 doses, and it really didn't have much in the way of side effects. So it's a good technology. This technology was adapted to the use of COVID and had some benefit. People were focusing on the percentages, not recognizing that really the big message for all these vaccines was that nobody was getting seriously ill. Nobody was dying that got vaccinated, which is really an awesome thing. It was a single dose vaccine. It had a lot easier storage requirements, which was awesome. That was great. It allowed it to be thought of and more widely disseminated amongst not only this country, but elsewhere. So preliminary data, additional information is that this probably does have some prevention in terms of disease. It's not perfect, but it does have a prevention. Remember, these trials were done in different times and different geographies, but they do have effect, and they also have effect against the variants. Now, is it perfect prevention or perfect? No, the answer is no. But during, for example, the Johnson & Johnson vaccine, when they were trialing it in South Africa, all the strains circulating in that South African strain of people that were getting exposed were all that South African variant strain. So it still had effect. Nobody died after getting vaccinated, so showed a major benefit. This is just, I'll pass over this because it's getting long for the tail. Vaccine events, this is the most recent data reported out of 13,000 cases. Anaphylaxis is not common. It's at the same level of other accepted vaccines, pneumococcal vaccines, zoster vaccines, the most common side effects being headache. There are some unusual cutaneous reactions to look at. These are delayed reactions that look like rashes, plaques, but not a contraindication. I'm going to skip over some of this because if you need to look at it, it's online. Vaccinations, we've delivered 116 million doses. And at this time today, probably over 60% of our population over 65 years of age has been vaccinated at least with one dose, which is awesome. Those are the highest risk patients. And if you look at the outcome in Israel, where they have vaccinated probably over 80% of all the high risk patients, people getting hospitalized are not the elderly. They are the young people that are getting hospitalized because the vaccine has had a major impact on their sickness. This has led to some changes in what CDC just came out with yesterday, saying that fully vaccinated people can now start to resume more normal lives, meaning you can get together with other people that are vaccinated or at low risk. If you're in a higher risk situation, you're still suggested to use the normal masking and social distancing, but that gives us a glimpse to what's happening down the line. Moving on, this is the very beginning. We're beginning and we're starting we had no treatments. The only thing we had to use is low-tech masking and stuff like that. And we did blunt things, allow ourselves to catch up and learn some things. One is, these are the last couple of slides. One, communication is critical in terms of how we deal with this pandemic, how we deal with future pandemics. And we had we showed that the need for leadership is very important. Trust is so important. And we did lose some trust in how things were communicated, whether it was at the presidential level, at the public health level, but a lot of those things were injured during the time. And this is also occurring at a time of different social structure, where the internet, where our communications are, where we look at information and it's difficult to figure out where the truth lies. Collaboration was critical, was important. We worked together to mitigate and contain, to share best practice. We got together on a cell phone. We had Zoom conferences. We talked to people across the country. We met together as groups to figure out, what are you doing? What are we doing? And what works, and kept track of that. And it led to better care for our patients and our healthcare workers. We still need to better communicate the science and risk communication. That is still, if I can tell you why, and you trust me, then things can happen. If I can't tell you why and explain it and show you the information, then it's harder to have everyone behave in a safer way. Operations management was critical for us. We had great leadership at the local levels between all the hospitals, the different CEOs, COOs, CNOs, different levels from all the structures from nursing, the physician levels, the critical care, environmental. Everybody participated to try to make this a better place and to make this work. And that was critical. Flexibility. We all learned that we can't do things the way we did them before. And some of us were kicking and screaming, but we had to figure out ways to still make care occur, whether it was telemedicine, Zoom meetings, whatever it took to keep it safe. And recognize also that public health structure is still critical to prepare and continue, and we need to continue investing in our public health infrastructure. This was an outbreak that required cooperation between the state, the federal, the local, community level, county level. There was never more of an example of where you had to get on the phone and talk to your local health official to figure out what was going on. We learned a lot of things that were happening before they were ever published by talking to our local groups of people and creating those relationships that were important to deliver care for our patients. And then we learned, of course, that whatever happens, that what is ongoing in your society, whether it is people need better housing, better health care, better management of their chronic health conditions, all that remains important because at some point in the future, this is going to happen again, where something will attack us and have a slightly different effect, but it illustrates what's going on in your society, whether we have to have alternatives to deal with some of the stuff, but you can't escape it. It will highlight where your problems are. So what does the new normal look like? We'll continue to work with vaccines and therapeutics. Hopefully we'll have an oral agent available within the next within the next year, which would be fantastic. We'll still have to do some public health measures in terms of masking as we gather, that first, it's the first light at the end of the tunnel to say that vaccinated people can get together. And as we learn more about primary prevention from these vaccines, and that we really lower the incidence of the disease in the community, things will open up more and more. Testing is going to continue to be a focus where we have to have cheaper and faster and more available testing, potentially in the household. And transmission disruption, especially as we get cases to be very low. Remember, when cases are too high, public health is overwhelmed. But if we can use our public health infrastructure to really track down new cases, we can prevent it from taking off, even new variant strains from taking off in the community. And then variant sequencing and surveillance will continue to be important to get an idea of what's happening with variants. We'll have to still have community cooperation, public and private partnership, which has been important in terms of moving forward with our PPE. I mean, who would have thought that Toyota would be helpful in creating masks and face shields? Isn't that that's an incredible story? That's people pitching together and using what you have in your own community to help address a problem. And that will need to still be there in the future. Lastly, thanks to all who served. It's been a long road. Hope you got something out of that. But I really appreciate all those people, the sacrifices. It was a lot of work for everybody, and appreciate everything everybody's done.
Do we have time for a few questions? You can ask some questions in the chat box. One of the things that I wanted to clarify is about the vaccine. So none of the vaccines are actually really live viral vaccines in the terms of being able to replicate in the human body. So for patients that have contraindications to live viral vaccines, any of these vaccines can be given. Of course, the messenger RNA vaccines are just messenger RNA and a lipid envelope. They're not live viruses. The adenovirus vector vaccine is actually a deactivated virus. So it's a human adenovirus that's been altered so that it cannot replicate in humans. So we don't have to worry about that being a typical live virus vaccine that's going to develop an overwhelming viral infection in the immunocompromised host.
Are there other viral protein targets for vaccine research other than the spike proteins so that vaccines can be effective against different strains?
The vaccine, the primary method for immunity to date is still spike protein. They did look at they've already looked at other parts of the virus, including nucleocapsid protein, et cetera. So those tend to be not as effective. The spike protein has been the major focus because it seems to, in animal, they start with animal models like macaques and stuff like that, looking at response. Tends to be the spike protein response as the marker. Now, the issue is what happens when the spike protein changes. That is going to be addressed by looking at those changes and creating new genetic code to put into likely a booster if it changes to a certain, and they're working on that. Moderna and Pfizer, and I'm sure Johnson & Johnson, all these use similar technology in terms of getting the genetic code for the spike protein changes and then creating that as a likely booster. So that's going forward. But they already have looked at other parts of the virus and their effect are not as robust.
And there will be other vaccines coming out in the next month or two. Novavax in particular is pretty far along.
Two questions kind of go together. Do you think COVID-19 may become another seasonal epidemic like the flu? And would people then need frequent vaccinations yearly or quarterly?
Well, I think it's pretty clear that that's likely to happen. I mean, we think looking backwards, if you look at the other coronaviruses, the OC43 was probably responsible for the, in quotes, Russian flu in the 1890s that probably killed around 1 million people in the US. And now it's circulating as a common cold virus. So that's probably going to be the model for COVID-19 going forward as more people develop immunity. We'll still be able to become ill from it, but hopefully the vast majority of people won't become severely ill. And that's really the purpose of the vaccine. It's not, we think that it's going to significantly cut down on the number of infections, but in particular, the severity of infections. We think that updated vaccines will be needed, as we've seen over the last couple of months with the variants. The vaccines and natural immunity are not as effective against the variants, and so we'll have to have continued adaptation of the vaccines. And we don't know at this point how often we'll need a booster shot. That's what the vaccine trials are looking at. The J&J trial now, because we did it later and included a number of healthcare workers that were able to unblind early in the trial if they had placebo. They were able to get the Moderna vaccine or the Pfizer vaccine. And we're following all of those people in the trial for over 2 years, and we'll know about the durability of the vaccines, and in fact, the durability of all of the vaccines, even in that one trial.
You're gonna follow patients this is gonna be under surveillance for the next number of years. Well, if you can significantly vaccinate and have protection in the community, you will then be able to do surveillance, find what's happening with these new variants. But it would, if the virus, the more you have less transmission, the less transmission that goes on, the less opportunity there is for variant to develop and to spread. So that'll be something that is ongoing. Now, we do those kinds of surveillance for other illnesses like the flu. We always concerned about the flu. If the flu changes significantly and the vaccine doesn't match the flu, you have a spike in the significant number of flu cases, and then you go back and try to figure out how to address that. So that will likely also be part of this. And
that points out another critical factor. In the United States, we're breathing a sigh of relief. The number of cases are precipitously dropping. The number of deaths are precipitously dropping. But that's not true in other parts of the world. Just earlier this week, Brazil had 2 days in a row where they had the most deaths that they've ever had in the whole pandemic. Even in Europe, in numerous countries in Europe, the numbers plateaued and now are going back up. We have to help the rest of the world in terms of supplying vaccines to the rest of the world for humanitarian reasons and for selfish reasons. Because if we don't help the rest of the world get over the pandemic, we don't supply vaccines to the rest of the world, we're going to get a bigger onslaught of new variants that will potentially cause new surges.
Yeah, worldwide, remember that the number of people vaccinated worldwide, even if you have 300 million, it's only point something percent. It's low. And the story in Brazil, again, is because you don't have, the vaccine is not rolled out at all for the most part. And you have an experiment in natural infection and then a new significant variant strain coming in there causing disease. So we need to be able to vaccinate to kind of blunt that whole effect, blunt transmission. And that's to be seen. Well, we'll be looking at this going forward.
Are you aware of any studies being done concerning patients who develop shingles after getting COVID vaccines?
You know, there are the signals that people, some of the signals people worried about, what happens after you. So there are people that there's no increase right now of shingles. There's no increase of Bell's palsy, but there are people that report that I got shingles after the vaccine, that I got Bell's palsy after the vaccine. So what you have to do is and this is ongoing and going into the future. You had the first look at the first 13 million doses. That's a lot of doses of vaccine that came out within the last month or so, reported. It's an ongoing surveillance system. So looking for adverse events is always going to be looked at, looking for anaphylaxis, looking for these weird rashes, looking for shingles, looking for Bell's palsy, all those things. You know, autism. People are going to say, what about autism? What about this and that? They're going to look, but right now there aren't any of those signals, but that's going to be looked at. And right now that information is, I'm sure there are going to be a case report here and there, but to say that it's increased over baseline is the answer is no, not right now.
Now that outpatient remdesivir is available, which patients would you use Regeneron on, and which ones would you use outpatient remdesivir on?
There is no outpatient remdesivir at this point. It's just not a general standard. That's something that's being discussed, but it's not there.
So it's clear
remember that it's the people that benefit from remdesivir and the steroids at this point are not outpatients in the setting that you have to have. The signal in those studies, whether it's a recovery study or not, was that you had to have some evidence of more severe disease. That was oxygen use. Now, could there potentially, and because this is still a new illness, we are concerned about treating patients with respiratory failure as an outpatient, because they could progress and get sicker and you need to intervene quicker. Will something evolve over time? That's possible. We have evolved over time, plus how to give it safely when a patient's actively infected. All that stuff is not worked out, but I will say that a big breakthrough will be an oral antiviral. So if the oral antiviral like Tamiflu or something along those lines is available, those patients will benefit. They may be the ones that benefit, and they get treated earlier as outpatients, keep them out of the hospital, and they may have some benefit.
But remember, at the present time, the monoclonal antibodies should be used very early in high-risk patients. We think that the initial trials on the monoclonal antibodies didn't look that great because they were used in patients who were ill who had been ill up to 10 days. If you wait until the patients are 8, 9, 10 days in the illness, we don't think they're going to show much benefit in that situation. If they're high-risk patients, and that's 65 or older, BMIs greater than 35, or if they're 55 or older, comorbid conditions like diabetes, hypertension. If they're high-risk patients, the earlier the better, preferably in the first 1 to 2 days of illness. Now that's hard to do because the diagnostic tests oftentimes don't come back that quickly. First off, the patients have to present to you. You have to get the diagnostic test and get the result back. And then you have to bring an infected patient in to the healthcare setting to administer the medication. So it is hard to do that. We were almost on the verge of abandoning the monoclonal antibody therapy because of the data not really looking that great and the difficulties of administering it. in a situation where we had constraint of resources. But then we discussed this situation with some of the ID doctors at Vanderbilt and other places, and they have unpublished data, which is gradually coming out about early administration in the first 2 days of illness, significantly reducing mortality, reducing hospital stays, and so forth. And I think that's why the tide has shifted really in terms of Infectious Disease Society of America and NIH recommendations for monoclonal antibodies just in the last week or two. But remember, earlier is better. On the other hand, with remdesivir, we're using that at present. In the second stage of illness, the monoclonal antibodies early in the first stage, the remdesivir in the second stage, which is the pneumonitis stage manifested by hypoxia. We do want to catch it early in that stage. We think that the remdesivir is more effective early in the stage of the pneumonitis stage, in particular when the O2 saturation is consistently 94% or less. We're considering that an indication for intervention with remdesivir and steroids, and not really waiting until they're in the patients are in the 80s, because the patients tend to do more poorly and the treatment is not as effective. I think we've gone on pretty long. I think maybe
We're going on now. Today is actually Wednesday. No.
Well, two more questions. Okay.
Is it fair to say that only the death rates tell us incidence given reduced interest in testing?
The death rates tell us what?
Is it fair to say that only the death rates tell us incidence given reduced interest in testing?
No, I mean, incidence is the new cases going on in your population. And you can get that, you get a certain sense of it by looking, it depends on when you're looking at an outbreak. For example, in the beginning of an outbreak, your incidence is probably underestimated because you're looking at only severe illness and getting a positive PCR in a hospital setting, not recognizing, especially in this case, for example, that there were a lot of asymptomatic infections. So we didn't really focus on that. People aren't going to get tested initially unless they get sick. Serosurveys give you a better idea of incidence and prevalence in the community. And that's just something that's going to have to take some time to be sorted out. We already have signals that, what goes on in the community is still probably undercounted. But over time, we'll get more clarity on that. So I think incidence is probably underestimated. We know, for example, looking at what happened a year ago, that the virus is already probably circulating in numerous countries, including the United States, and we just didn't have it. I mean, initially you started by saying, well, the first case was in Washington. Well, actually, when they went back and did autopsy study, they found cases with positive COVID in December in California. And they're going, what the heck? That this is not, because it wasn't on the radar. It wasn't really a reported illness, and it just took some time to figure that stuff out. We will get to that at some point.
Well, and the other things you can look at are your positivity rate and your hospitalizations and your number of ICU patients. So at the peak of the pandemic, we had 80 or maybe a little bit more than 80 patients at Baptist Hospital Lexington in the last few days. It's a tenth of that, down to 8. We went for one 12-hour period with no one who was on airborne precautions in the ICU. It was a pretty dramatic change. So we can, just aside from testing, we can see it in the healthcare setting that the pandemic, at least for the time being and hopefully permanently, is ebbing.
And we remember that we're going to take away, by vaccinating and by actually getting people getting sick and people vaccinating, the number of susceptible people in the population is really going to drop over time. Now we have a major intervention in terms of vaccines to decrease susceptibility for severe illness, at least. Those patients aren't going to be making it into the hospital. So what's happening in the hospital is really going to go down. But we still need to keep track of what's going on in the community. So they will continue to do surveillance to see what's going on, doing serosurveys and having public health involved in that, looking for variant strains, all that type of stuff is going to continue to go on.
So Dan, what proportion of the population do we need to have vaccinated to have herd immunity?
Well, nobody knows, okay? There's been so much discussion about what's that percentage? And they haven't put out enough science behind saying, well, we talked about 16, 70% of the population being susceptible. Then Fauci comes out and says, well, maybe it's 85 or 90.
With the new variants.
Yeah.
Yeah.
I think you're probably going to have higher than lower, and meaning probably along the lines of 70 or 80% to really kind of look at the dynamics of decreasing the ability of variants to spread and decreasing the number of susceptibles out there. Because even if you get sick with, and you've been vaccinated, it is likely, and this has been shown too, that when you're vaccinated, your viral load is lower. Even if you get sick, the viral load is lower. So you're probably less contagious in some respects than you would be if you weren't vaccinated at all. So all those dynamics will be important in terms of transmission in the community. But the exact percentage, I don't think they know that yet. I mean, they just kind of postulate what they think.
I mean, it looks to me like with voluntary vaccine administration, we'll probably get to around 60% or 70% of the adult population vaccinated. We know that there's some people in the population, maybe 15%, that will never get vaccinated under any circumstances unless they're somehow compelled to. But then there's a component of the population that's vaccine hesitant. Maybe, and I think that's changed over time. I think there was a bigger proportion earlier on when people didn't know about the vaccines. It was new technology, especially the mRNA vaccines. I think that proportion of the population, if you look at surveys, has dropped down to maybe 10 or 15% that are really vaccine hesitant at this point. I think it's not going to be too long, in the next, probably the next couple of months, where we have actually an excess of vaccines. Anyone who wants to get a vaccine, who's eligible, who's 16 or over, will be able to get one readily. And then as a healthcare systems, we're going to have to deal with the vaccine hesitant to get over the hurdle in terms of herd immunity. So I think at some point it's going to be incumbent upon all of us as healthcare providers to discuss those issues with our patients. And I think there's some patients that will not agree to a vaccine without discussing it with their healthcare provider first, instead of just going into a mass vaccination clinic. So I think it's going to be important for us as providers to discuss this issue with our patients. Try to discuss it every time someone comes in. I know I am, and I'm sure you are.
Well, it's going to be majorly important to focus on also the high risk categories. I mean, like patients that are the elderly, somebody over 65, somebody with comorbidities, that will have a major impact. The other thing is that your younger people are going to be a little less symptomatic. And symptoms probably also matter in terms of how contagious you are. There is some data showing, though, if you're asymptomatic, even though you transmit, you're less contagious than if you're symptomatic. And it kind of makes some common sense in terms of somebody coughing and spewing all over the house versus nobody doing anything. So that's more to come on that. But I think the way we've rolled it out has been good. We're trying to maintain a drill with high-risk populations. We're trying to deal with maintaining infrastructure to deliver care, and that focus has been good.
And remember, we have underserved populations that have less access. I think public health is attempting to deal with that. The government's attempting to deal with that. One area that I think
less access and also less belief because of previous issues, like communities of color not really buying into some of the vaccine information because of previous history, which is interesting. The history never goes away, whether it's Tuskegee or something else like that. That history gets carried forward in communities, and then it gets applied to the current situation. Even though it's been discussed, it just shows you that you still have a long way to go to understand where the history is, understand where this is at, to try to gain trust. People don't have trust. That's something that needs to improve.
And remember, another subpopulation who will be harder to reach is especially elderly patients who have limited internet access. A number of elderly patients don't have computers, they don't have internet, they don't have smartphones. And guess what? That's how most people are signing up for vaccines at the vaccine clinics. So just keep that in mind as a healthcare provider, that your staff or you may have to assist them in getting access to a vaccine. Okay, one more.
If a patient had an allergic reaction to their first dose vaccine, such as Moderna, should they avoid any future COVID vaccines, even a different type?
The answer is no. It depends on the.
It depends on the severity of the reaction. Yeah.
Anaphylaxis, they wouldn't have you take the second dose.
Yeah.
But anything else short of that, essentially, for example, those unusual rashes, the answer is that they basically recommend that you still get your second dose of vaccine. So that's something to discuss with your provider.
So one consideration there would be the J&J vaccine, because we know that the Pfizer and Moderna tend to, at least with the second dose, tend to have a higher incidence of more severe reactions. In the trials, we saw very few severe reactions with the J&J vaccine. So that might be a consideration to get vaccinated if you had a severe reaction with the first dose, to get vaccinated with the J&J vaccine to make sure you're fully vaccinated.
But really, the severity is, I will disagree a little bit. It's just that the severity, people got to define that.
It depends on the severity.
Well, it's like, for
the
example,
fever,
I got a
that
fever
doesn't really count.
And they say, I'm just
But-
too sick, so I'm not going to do it.
But
So I
prostrate
would
for a
say-
week, that might qualify.
I would say in general, the only contra would be if you had anaphylaxis. Everything else, because, you know, there's plenty of historical information that if you delay and don't get vaccinated, you won't get vaccinated. I mean, there's a million articles written like that, lost opportunities for vaccination. So you have an opportunity for a vaccine, whether it's a flu or a COVID or something, you got to take the thing. And that's based also on millions of people doing these trials, and the fact that you do fine usually with the second.
Okay, so I think we may try to do this again, but probably wait for a few months until we have more data back on the variants and the vaccines, and we'll see.
We'll see. Oh my God.
It's a lot of work. Thank you, Dan, for putting in hours and hours of research and work on this. Thank you very much.
Hopefully we
Okay.
got something out of it. See